Hey guys, today we're going to talk about evaluation and management of infectious disease. Um, you can read the chapters in your book to get more of a sense of infectious diseases. Lots, okay? What you're going to be tested on are what I'm going to lecture on, and also the readings too. So make sure you read the articles that I give you. There'll be some questions on that. Also, those articles for Zika and TB, the up to date, they're up to date. So make sure that you look at that and not your textbook. In class, we are going to do a case study on endocarditis, which is managed by ID, which was in your cardiac lecture, but it is managed by infectious disease. So we're going to do a case study on that. And I think the other case study might, I'm still deciding on what I'm going to do for the second case study. So it will be a surprise, but it will be something that is in your readings, okay? So tick-borne Lyme disease is tick-borne inflammatory disorder caused by the spirochete Borrelia burgdorferi organism. Erythema migrans, EM, is a clinical hallmark followed weeks to months by neurologic, cardiac, or joint abnormalities. This is the bullseye rash. Questions are always asked about erythema migrans, clinical hallmark on the boards, so you need to know that. All stages of Lyme disease respond to antimicrobials. Response to treatment of early disease is the most effective. Lyme disease, 68% report erythema migrans rash. Know that you don't have to have the rash in order to have Lyme disease. This usually appears 1 week to 1 month after the tick bite. Timeline. First, you're bitten by a tick. Second, 1 week to 1 month, you get erythema migrans. This is associated with constitutional signs which consist of fatigue, myalgia, arthralgia, headache, conjunctivitis, lymphadenopathy, fevers, and stiff neck. You need to distinguish this from a common cold. And basically, a common cold, if you have a common cold, you will have a sore throat, rhinorrhea, and cough. Those with Lyme disease do not have that. 1 week to 7 months after a tick bite, usually 1 to 2 months, you get signs of disease dissemination, which are Bell's palsy, neurogenic bladder, subtle signs of encephalitis, which may look like meningitis, but patients who have meningitis have a much more severe headache. They do have neck stiffness, so they have less severe headache and neck stiffness than bacterial meningitis. May have dissemination of the heart, which means basically they have conduction abnormalities and they have complete heart block. So you need to do an EKG. You need to look at any conduction abnormalities, looking for complete heart block. We know that from 1 week to 7 months, oftentimes patients complain of arthritis-like symptoms, usually in a large weight-bearing joint, the knee. Left untreated, it becomes chronic, and oftentimes there'll be nervous system involvement, which examples of that are fibromyalgia or immune dysfunction. Blacklegged tick nymph. It's the size of a poppy seed. They transmit most cases of disease because they are so difficult to detect. They seek blood mail from mid-May to mid-July. Typical bullseye rash, several concentric circles, expands over time. It's painless, it's raised, and may be warm. Secondary annular lesions, which you see here. Okay, these are a good example of secondary lesions. Reaction as bacteria moves through the body. It's not caused by multiple tick bites. When you see secondary annular lesions, really This is a question, they need to be admitted, and if they're not admitted, they're close follow-up, very, very close follow-up. Early Lyme disease, stage 1, at or before the onset of symptoms, can be cured if treated properly. Disseminated Lyme is stage 2. Multiple major body symptoms are affected, and it's much more difficult to treat. And chronic Lyme disease is stage 3, ill for 1 or more years. Serologic tests less reliable. Treatment must be more aggressive and of longer duration. Clinical features. Early Lyme disease, erythema migraines, localized, and may have multiple. Remember that not from multiple tick bites, but from spread of bacteria. These patients are sick. They have flu-like illness. Early disseminated Lyme disease, they can have neurologic symptoms, which are cranial neuropathy, meningitis, and radicular neuropathy. Joint, they can have acute inflammatory large joint arthritis or carditis as well in early disseminated Lyme disease. Late Lyme disease, neurologic, they can have peripheral neuropathy or encephalopathy and or chronic arthritis on late Lyme disease. Joint swelling and pain may occur weeks to months after onset of illness if left untreated. Most commonly knee and shoulder joints. When I was a new NP, I had a patient with knee. I had a patient with knee pain. She was a painter. It was in, I want to say, January. And she came in with knee pain, and I was a new NP. It wasn't reddened. It wasn't swollen. And she said she didn't injure it. I thought it would be overuse injury, but I remember looking up the differential, and one of it was Lyme disease. You know, she didn't have a rash. She didn't have a tick bite. She didn't report that she was in the woods. But know that Massachusetts really is, Lyme is the flu of Massachusetts. So I did a Lyme disease on her, and she thought I was crazy, and she was positive for Lyme. So, you know, a diagnosis not considered oftentimes is a diagnosis missed. So know that you are a new NP. You need to think broadly about your differentials, okay? I'm not saying to look at all these weird zebras, but Lyme is very common in Massachusetts. So Lyme wouldn't have been off of the differential going down a road that, you know, and after that, as a new NP making that diagnosis, you know, 17 years ago, I thought it just kept in my mind. So remember that you need to be looking at differentials based on symptoms that patient presents. So you remember that you need to have a broad diagnosis that's considered so you don't miss something. So system, based on the symptoms of Lyme disease, you have these patients on stage 1 have influenza-like symptoms, stage 2 malaise, fatigue, and stage 3 fatigue. And then stage 1 is 3 to 30 days post-exposure, stage 2 are weeks to months post-exposure, and stage 3 is months to years post-exposure. So you see lymphatic, you have from 3 to 30 days regional lymphadenopathy. Stage 2 lymphatic, regional, or generalized lymphadenopathy. Know that that's an important thing to write in your system. Cardiac, 3 to 30 days, none. Stage 2, weeks to months, AV block, myopericarditis, or pancreatitis. Musculoskeletal, 3 to 30 days, myalgia. Stage 2, weeks to months, is that pain in joints, just like that presentation I told you with that woman. She didn't have an injury. She had no trauma. She had no swelling, but she had severe right knee pain. Stage 3, months to years post-exposure, prolonged arthritis, attacks, and chronic arthritis. Neurologic, patients present with headache. Stage 2, weeks to months, meningitis, Bell's palsy, and or neuritis. Months to years post-exposure, patients can have encephalopathy, polyneuropathy, or leukoencephalitis. Skin, erythema migraines, the rash. Weeks to months post-exposure is those secondary annular lesions. Stage 3, months to years post-exposure, they can have lymphcytoma, acrodermatitis chronica, atrophicanes. And I'm going to show you a picture of that in a minute. That's what that is. So lymphocytic meningitis is an infection in the brain, and cranial neuritis can affect your cranial nerve number 7, which is your facial nerve. It's a form of cranial neuritis that is thought by many to be common. However, studies suggest that it may be seen in as few as 10% of patients with neurologic Lyme disease. Typically, a cranial neuritis occurs within days to weeks of the initial infection by a tick. If patients experience abnormalities in facial sensation, the cause may be inflammation of the trigeminal nerve. If central vision appears cloudy, or if there is pain on eye movements, painful extraocular eye movements are a really concern on any exam. These could be signs of optic neuritis. These patients can have what is called pseudotumor cerebri, and this is an intracranial increase in pressure that is not due by a tumor, but because of the increase in pressure, there's an inflammation, maybe pressure on the optic nerve. This pressure could cause visual loss. In rare cases of Lyme optic neuritis from Lyme-induced pseudotumor cerebri, blindness may occur if not detected and treated early. If cranial nerve 3, 4, and 6 are affected, the patient may present with double vision. With involvement of cranial nerve 8, patients may experience ringing in the ears, loss of hearing, vertigo, or ataxia. Also, facial palsy may be bilateral in Lyme disease, not always. A radicular neuropathy is when the infection in Lyme disease affects the nerve root. It is called radicular neuropathy. Typical symptoms include radicular pain, symmetric or asymmetric sensory abnormalities, and that's you want to measure the upper extremities and lower extremities, the hand, the dorsal, and the palmar aspects of the hand for any numbness or tingling, sensation to sharp and light touch, and you have to do a really, really detailed neuro exam. Radicular pain with radicular neuropathy may be experienced as sharp stabbing or burning or shooting pain that radiates down arm or leg. Chronic skin conditions, which I talked about, acrodermatitis chronica, atrophicanes, also known as Herxhema disease. And basically, you have primary diffuse atrophy. It's a skin rash indicative of the 3rd or late stage of Lyme borealis. It is a dermatological condition that takes a chronically progressive course and finally leads to widespread atrophy of the skin. This is an involvement of the peripheral nervous system, is often observed, specifically also polyneuropathy, it's called. The progressive skin process is due to the effect of continuing active infection with the sporocyte Borrelia apfelsia. Apfelsia is the predominant pathophysiology, but may not be the exclusive etiological agent of ACA, which is acrodermatitis chronica atrophicanes. A lot of studies have shown Borrelia gorinea that also has been detected. So that's a mouthful with all of these organisms and what they're called. When you have someone that has this, you'll be working with ID. Lymphocytoma is a benign cutaneous disorder, and you can see the picture. It's characterized by collections of lymphocytes, macrophages, and dendritic cells in the skin. Lyme disease diagnostic studies. Presence of erythema migrans is considered diagnostic. You got to know this. If present, treat patient for Lyme disease. No diagnostic tests are indicated or necessary. There are times when patients come in, it doesn't quite look like erythema migrans. People present differently, but if it's in the summer, it's in the fall, we might go ahead and treat with one-time dose and then do the actual Lyme test and see, and if it's not, then we'll stop the treatment. Because Lyme, again, is the flu of Massachusetts, you really want to make sure that you treat, and then if it's negative, you can always just stop the treatment. Now, I'm not talking here about overly treating everyone that has impetigo and we think it's like Lyme. I'm talking about we're not sure, but it might be. In the history, based on the patient review of systems, that this might most likely will be Lyme. Now, you're going to have patients that come in and basically say that they got bit, they had a tick on them, they don't have the tick, they don't have a rash. Those are patients that you have to watch very closely, not necessarily treat them with doxy. So again, there is a lot there. It isn't always black and white. There's some gray areas. It's really important that they have follow up with their primary care provider. And if we're drawing something in the ER, like someone like this, I might end up doing a Lyme panel on this patient that I'm not sure about, and then we'll call them back. And if we started the treatment, we'll talk to them and say, you know what, you might get a phone call. I'm going to go ahead and treat you. If it's negative, then we're going to stop the treatment. But these are people that you still are going to watch for the next 30 days. Enzyme-linked ELISA for antibody detection. Also, wait, let me back up, sorry. Presence of erythema migrans is considered diagnostic. If present, you treat patient for Lyme disease. No diagnostic tests are indicated or necessary. If there's erythema migrans, what I do, we go ahead and treat it, and then they do the blood test 2 weeks after at the primary care. Enzyme-linked ELISA for antibody detection, IgM, elevated 2 to 4 weeks after exposure and declines 4 to 6 months after exposure. Should only be used for diagnostic testing within 4 weeks of exposure due to increased risk of false positive results during late stages. So IgM is elevated 2 to 4 weeks after exposure and declines 4 to 6 months after exposure. So if they just had a tick on them, okay, and they basically had a tick on them, they said it most likely was there for 2 days, this IgM is not going to be positive. It's going to be positive in 2 weeks. So oftentimes you can go ahead and get the baseline lab work. A lot of times it depends on when they were bit and when the tick is on. If they have no erythema migrans rash, but the tick is on them, 2 weeks, you can get their ELISA in 2 weeks. IgM is elevated in 4 to 6 weeks after exposure and remains present in low levels even after successful treatment. Western blot as a confirmatory test done if ELISA testing is positive. So if someone, you got to let them know that first test might be negative, but that doesn't mean they don't have Lyme disease, so they need to be followed closely with their primary. Empiric antibiotic prophylaxis is not recommended for patients who seek care after a tick bite and are asymptomatic. These patients should be asked to return immediately if they develop any signs or symptoms of rash, fever, or arthralgias. If a patient presents with nonspecific systemic symptoms, arthralgia, myalgia, and paresthesia, and lives in an endemic area, they should be tested for Lyme, but not treated empirically. Antibiotics for Lyme, 1 to 2 weeks post-exposure, body begins making IgM. 4 weeks post-exposure, body begins making IgG. 4 to 6 months after exposure, IgM levels decline. IgM and IgG can both persist after treatment and treatment of infection and do not necessarily mean that they've been re-exposed. Treatment: early local disseminated disease, isolated facial palsy. These are the drug therapy, doxy, amox, or cefuroxime, 14 to 21 days. Remember, you have to do a lot of teaching on the risks of doxy and the burn, okay? You really, really have to do that. Multiple erythema migraines, doxy, amox, or cefuroxime, 21 to 28 days. So that's multiple. Bullseye rashes, the bacteria is spreading, so that's a longer, 21 to 28 days. Arthritis, intermittent or chronic. Doxy, amox, ceftriaxone, or penicillin G, 30 days. Neurologic abnormalities, ceftriaxone, penicillin G, and cefotaxime, 2 to 4 weeks. High degree AV block, ceftriaxone or penicillin G, IV or IM for 30 days. So that's Lyme. If you have any questions about that, you're going to be treating a lot of Lyme in Massachusetts if you practice. And there's a lot of ongoing debate. I think one of the biggest ones is if you have a patient that had a tick on them but has no symptoms and no rash, and it's been there for 2 days, do we give one-time dose of doxy? And the evidence says we do, if they can confirm that it's been on there for 2 days. In reality, that's tough. You know what I mean? It's tough the patients don't know if it's been there on for 2 days. So you have to make your clinical decision and decide what, are these patients going to come down with Lyme? Are they going to be followed up with their primary care provider, or should I just go ahead and treat one-time doxy? You're going to have a lot of patients that think they were bit by a tick and it wasn't a tick. So it depends on who's presenting in front of you. Now, if you have a landscaper that says the tick was on there for 2 days, then I would, even though they're symptomatic, I would treat, because the landscapers are the ones that, are exposed to the woods a lot, or someone who works in the woods all day, which, like camp counselors who are nature tour guides in the summer. That's an example. Okay, tuberculosis is spread by droplet nuclei. It's expelled when a person with infectious TB sneezes, coughs, speaks, or sings. Close contacts are at the highest risk of becoming infected. Transmission occurs from person with infections of TB disease. It's not latent TB that's infectious. 10% of infected persons with normal immune system develop TB at some point in their life. Risk of developing TB, 7% to 10% each year. Immunocompromised patients have increased risk that TB infection will progress to TB disease. Most exposed to TB do not become infected. Drug-resistant TB is a major problem. It's transmitted the same way as drug-susceptible TB. Drug-resistant is divided into 2 types. Primary resistance develops in persons who are initially infected with resistant organism, and secondary resistance, which is acquired resistance, develops during TB therapy. Risk factors for TB. Those are elderly, those who are economically disadvantaged by racial or ethnic groups, those who are malnourished, infants and children under the age of 3 or adolescents, those with reduced immunity and HIV disease, those living in overcrowded conditions, who are homeless and who are in jail, who are been incarcerated, and immigrants from high prevalent areas. Persons at high risk for exposure to or infection with TB should be screened. Those with close contacts of person known or suspected to have TB, foreign-born persons from areas where TB is common, residents, employees of high risk areas that have multiple people living in those settings, nursing homes, healthcare workers who serve high-risk clients, medically underserved low-income populations, high-risk racial or ethnic minority populations, and children exposed to adults in high-risk categories. Persons who inject illicit drug use are also at high risk for TB. Persons at the highest risk of developing TB once infected are HIV infection, recently infected, persons with compromised immune system, persons who inject illicit drugs, and those who have a history of inadequately being treated for TB. So, administering the tuberculin skin test, you want to inject intradermally 0.1 ml of PPD, which is a protein, which produces a wheel of 6 millimeters to 10 millimeters in diameter. You want to read the reaction in 48 to 72 hours after injection, and you only measure only the induration, and you record the reaction in millimeters. Classification of TB reaction. Reaction is greater than or equal to 5 millimeters. This is considered positive in patients who are HIV positive, recent contacts of TB case, persons with fibrotic changes on chest X-ray, which is consistent with old healed TB. So those with a positive X-ray. Person with organ transplant or immunosuppressed patients. Patients who have an organ transplant are on immunosuppressive medications, which makes any reaction greater than 5 is considered positive in patients. Classification of TB reaction. Reaction greater than or equal to 10 millimeters is considered positive in populations who are recent immigrants within 5 years from high prevalence countries, those who are IV drug users, residents and employees of high risk, areas that have multiple patients or individuals living in that setting. Those who work in the lab with microbacteriology with bacteria are also, if they have a positive PPD of greater than 10, it's considered positive. Children, adolescents exposed to adults in high-risk categories, persons with medical condition that put them at high risk. In all persons, a reaction greater than or equal to 15 is considered positive for TB. Factors that may affect the skin test reaction: you can have a false positive from a non-tuberculosis microbacterium. You can also have a false positive from a BCG vaccination, which oftentimes people from other countries have BCG vaccines. You can also have a false negative from a recent TB infection or anergy, or very young individuals less than 6 months. So anergy is a term in immunobiology that describes a lack of reaction by the body's defense mechanism to foreign substances and consists of a direct induction of peripheral lymphocyte tolerance. An individual in a state of anergy often indicates that the immune system is unable to mount a normal immune response against a specific antigen, usually a self-antigen. Lymphocytes are said to be anergic when they fail to respond to their specific antigen. Anergy is one of the 3 processes that induce tolerance induction, and it modifies the immune system to prevent self-destruction. So that anergy can give a PPD skin test as a false negative. So we have to worry about those, an anergic reaction to PPD. BCG vaccine results in the formation of antibodies against TB bacteria. If antibodies are present, either due to vaccine or infection, a PPD test will be positive and a chest X-ray is necessary to look for active infection. So 2-step testing. The point of 2-step testing is to determine whether the PPD can be used as a screening tool in patients with prior history of TB infection or BCG vaccines. In some patients with initial negative PPD, who have a prior history of tuberculosis, the PPD test re-stimulates the immune system to recognize tuberculosis. In these patients, a second PPD test 1 to 3 weeks after the first, not a long enough time span to have developed a new infection, will be positive, what is called a boost reaction. These patients should have a positive PPD in the future due to prior infection, and therefore it is not possible to determine from a PPD whether or not they have a new tuberculosis infection, so a chest x-ray is negative. In patients who have a second PPD test 1 to 3 weeks later that is negative, they have not had a boost reaction, and any change in future PPDs to a positive result can be considered the results of a new infection with TB. So if we go back to the chart, first test, positive, consider patient infected. If the first test is negative, you want to repeat the test in 1 to 3 weeks later. If the second test is positive, consider person previously infected. If the second test is negative, consider patient uninfected. BCG was developed in 1906. It's used in many countries, not in the US. Its attenuated strand of N. bovis may produce a positive TB test. There's questionable efficacy of this vaccine. It is only used in the US for infants and children with negative skin tests who are continually exposed to untreated or ineffectively treated patients. So patients who are not compliant, who have TB. Also, will be children who are continually exposed to multiple drug-resistant TB. Symptoms of pulmonary TB consist of prolonged cough, duration of 3 weeks, chest pain, hemoptysis, fever, chills, night sweats, weight loss, and fatigue. Here's an example of a chest x-ray with an encapsulated lesion where the arrow shows abnormality is often seen in apical or posterior segments of the upper lobe or superior segments of the lower lobe. May have unusual appearance in HIV positive individuals. Remember that chest x-ray cannot confirm the diagnosis of TB. Diagnostic tests or smear exams strongly consider TB in patients with smears containing acid-fast bacilli. Results should be available within 24 hours of specimen collection. This is a presumptive diagnosis of TB. Sputum cultures are considered gold standard but take up 12 weeks. They're used to confirm diagnosis. You culture all specimens even if smears are negative. Results in 4 to 14 days when liquid medium system is used. Sputum cultures are used when we suspect patient of pulmonary or laryngeal TB, and 3 sputum cultures are performed, and they are used to detect acid-fast bacilli because a positive smear is strongly suggestive of TB but is not diagnostic. Remember, with a positive smear, it may be due to other microbacteria, so that's why a culture is the gold standard. So we have to do 3 cultures, remembering that also a patient with TB may have a negative smear, and once we do the cultures, that is the gold standard. We go ahead and treat aggressively until we get the results back, if we think the patient has TB. Latent TB infection, you have a positive PPD, a negative chest x-ray, no symptoms or physical findings suggestive of TB disease. Monitoring, prior to latent TB treatment initiations, you want to rule out possibility of TB disease, determine history of treatment for latent TB infection or disease. You want to make sure that patient doesn't have any contraindications to treatment. You want to obtain information about current and previous drug therapy. You want to recommend HIV testing if risk factors are present. Active TB infection will develop in up to 10% of patients with latent TB infection who are not treated with preventative therapy. So we need to treat patients who have latent TB infection. There are two-stage treatment for active TB. You have the initial intensive phase, which consists of 4 drug regimens for 2 months. One is isoniazid, rifampin is the other one. Pyrazinamide is the third, and ethambutol is the fourth. Continuous phase for 4 to 7 months. In general, any patient with latent TB with a positive PPD who has an increased risk for exposure to disease are treated. INH 5 milligrams per kilogram per day for 9 months. In pregnant women, treatment for latent TB can be delayed until after delivery unless there is increased risk of progression to active TB. I just want to go back and important INH notes. Hepatotoxicity is a severe adverse effect. Risk increases with age in those who use alcohol. You want to tell patients to abstain from alcohol while taking INH. This medication is contraindicated in patients with active hepatitis or end-stage liver disease. Monthly monitoring, including adherence to therapy. You have to assess patients for symptoms of peripheral neuropathy and hepatitis. Signs of hepatitis are nausea, vomiting, dark urine, jaundice, or abdominal pain. And you want to monitor the LFTs. INH can interact with dilantin, so monitor drug levels in these patients. INH can cause peripheral neuropathy because of the interface with vitamin B metabolism, so you need to supplement them with vitamin B. Patients who are symptomatic, pregnant, seizures disorders, or diseases that increase their risk for peripheral neuropathy, and those are diabetes, malnutrition, and HIV. Treatment for resistance TB. So contacts of INH-resistant TB. You treat with rifampin and PZA. If unable to tolerate PZA, 4-month regimen of daily rifampin. So 4-month regimen of daily rifampin if they can't tolerate PZA, which is pyrazinamide. PZA, that's the abbreviation of pyrazinamide. HIV positive, 2-month regimen with rifampin and PZA. Contacts of multi-drug resistant TB, you use 2 drugs to which the infecting organism has demonstrated susceptibility. Treat for 6 months or observe without treatment if they're HIV negative. Follow for 2 years regardless of treatment. Monitoring response to treatment, you want to monitor patients bacteriologically monthly until cultures convert to negative. After 3 months of therapy, if cultures are positive or symptoms do not resolve, you want to reevaluate for potential drug-resistant disease and non-adherence to drug regimen. If cultures do not convert to negative despite 3 months of therapy, consider initiating additional agents. Monitoring at least monthly if receiving INH alone. Monitor 2, 4, and 8 weeks if receiving rifampin and PZA. You want to evaluate for adherence to prescribed regimen, signs and symptoms of active TB disease, and signs and symptoms of hepatitis. West Nile virus, RNA virus, the genus of this organism is, and genus is a classification of organisms, is genus Flavivirus. Also, it's a member of Japanese encephalitis serocomplex, and is closely related to St. Louis encephalitis SLE virus. It was found and isolated in 1937 in the West Nile district of Uganda. This is a mosquito-borne virus. It's found in what happens with the primary host is in wild and domestic birds. Spreads from birds to man and other animals via mosquitoes feeding on an infected bird and then biting another host. Mosquitoes that transmit West Nile virus and St. Louis encephalitis usually prefer to bite birds. Human infections with these mosquito-borne viruses are very rare and can be prevented by taking simple measures to avoid mosquito bites. Clinical epidemiology. Usually 3 to 15 days after birth of an infected mosquito, you'll get symptoms. Some patients are asymptomatic. Most infected with West Nile virus have no symptoms. West Nile fever may have mild flu-like illness, fever, headache, and body aches, and they completely recover in a few days. Some unfortunate ones come down with West Nile encephalitis, which is a serious illness with inflammation of the brain. Particularly at risk are the elderly or those greater than 50 years of age. High fever, severe headache, nausea, stiff neck, confusion, muscle weakness, paralysis, disorientation, convulsions, coma, and rarely death. 1% of humans infected with West Nile virus will develop serious illness. When they present like this in the ER, there's a lot of differentials. These patients are very, very sick, and they have focal neurodeficits. Diagnostic studies. Complete CBC, you'll have leukopenia, which is a low white blood cell. The lumbar puncture will have lymphocytosis, increase in lymph, which is not normal. Normal CSF glucose, and mild increases in protein concentration. So the lumbar puncture, it has lymphocytosis. West Nile virus serum or CSF IgM by ELISA. Best test, lab test for diagnosis, 95% sensitivity, so you need that spinal tap. Collect 8 to 20 days after onset of symptoms. Positive CSF IgM confirms CNS infection. So if you have someone with a headache, a fever, we're most likely going to do a spinal tap on you unless we can definitely pinpoint that it's not. It might be something in the cerebrospinal fluid. Remember, if you look at this, we need a spinal tap because the best lab test for diagnosis is 95% sensitivity, and that's CSF IgM. We can have serum or CSF, but it's 95% sensitive. No specific treatment, medication, or cure for illness caused by West Nile virus. Symptoms and complication of disease can be treated. Patients are hospitalized. They have IV hydration, pain control for headache, respiratory support. They're going to be intubated if they have acute flaccid paralysis. We want to treat and prevent any secondary infection, and there is no vaccine currently available for humans for West Nile virus. Practical risk reduction practices: minimize time spent outdoors, usually dusk and dawn. Wear shoes, socks, long sleeve shirts, and long pants. Consider using a mosquito repellent containing DEET. Eliminate stagnant and standing water and tight fitting screens at home. Make sure that you don't get any mosquitoes at home. Hold on, guys. I know I have some added stuff I need to add from the PowerPoint that you had in class. Okay, so the Enterovirus D68, EVD68, is a small non-envelope positive stranded RNA virus. This was a significant outbreak in 2015. So infectious diseases don't have to be, there are enteroviruses considered an infectious disease, but it impacted the US significantly. So this is the website for the CDC guide for enterovirus D68. And it's important to know that this was something that was a big concern for providers in the US. It was first identified in California in 1962. And not every enterovirus infection consistently causes disease state. Patients can have mild asymptomatic disease. It's very common. Likely greater than 10 million with EV virus caused infection annually in the US. Mode of transmission transmitted from person to person, direct or indirect, enteric or intestinal tract, or respiratory droplet. Most common in the spring and fall, and it occurs in children due to lack of immunity. Children were dying. Enterovirus-associated symptoms: hand, foot, and mouth disease, hepatoangia, hyperangia, myocarditis, coronary heart disease, chronic fatigue syndrome, encephalitis, and ADHD. So a lot of these patients with hand, foot, and mouth disease, hyperangina, myocarditis, coronary heart disease, chronic fatigue syndrome, encephalitis, and ADHD associated, they all had enterovirus, and they associate these conditions with that. Is there a lot of evidence that that causes this? No, but know that when something like this, outbreaks like this, we study this and we look at this, but there's no evidence that says one causes the other. Enterovirus-associated syndromes, type 1 diabetes, and we know that type 1 can be caused by a virus. And there's a growing body of knowledge to suggest that HLA and other genes coupled with prolonged persistent enterovirus infection associated with inflammation process in the gut mucosa contribute to the development of type 1 diabetes. Less common illness caused by enteroviruses are CNS infections like polio, meningitis, encephalitis, chronic meningeal encephalitis, acute flaccid paralysis, and numerous cases noted in recent enterovirus season. So very interesting. These are less common, but they have occurred. Enterovirus D68, what is it? It's a particular type of enterovirus. Until recently, in 2015, it was thought to be rare. What can cause this? Severe respiratory illness, acute flaccid paralysis, and other clinical syndromes. When to consider enterovirus D68 infection? This is a cause of acute, unexplained, severe respiratory illness with or without fever. Difficulty breathing, cough, wheezing, usually worse in children with airway disease. Those with asthma were dying from this EVD68 infection. Why was this particularly virulent outbreak in 2015? They're not clear, and the study is ongoing. Who is at greatest risk? Children aged 4 years and less. It's likely due to a lack of immunity with respiratory disease and those with smaller airways. The greatest risk time period is in the spring or fall, when multiple other cases of similar disease are noted. If considering EVD68 infection, laboratory testing of respiratory specimens for enterovirus need to be reported. You need to report suspected clusters of severe respiratory illness to local and state health departments. You want to contact state or local health departments before sending EVD68 specimens. EVD68 is not nationally notifiable, but tracking local outbreaks can help with control. And this is information on the CDC about testing for EVD68. Treatment is for these patients are very, very sick. Be supportive, treat asthma flare because a lot of these patients have asthma. No specific antiviral, antimicrobial therapy, no specific immunization, but have these patients have flu vaccine on board. Acute flaccid paralysis with the enterovirus D668 as a possible cause or cofactor, particularly in patients under the age of 21 years, presenting with acute flaccid paralysis, including absent or significantly diminished reflexes in one or more limbs, without a confirmed traumatic, neoplastic, or arboroviral or vascular etiology. The MRI with those with acute flaccid paralysis, MRI shows gray matter involvement of spinal cord, or EMG shows anterior horn disease. Remember, this is a possible cause or cofactor. Acute flaccid paralysis treatment, largely supportive fluids. They're on ventilators as required. They'll start them on a variety of antivirals, immunoglobulin, and other therapies were or have been attempted without apparent change in clinical course of disease. But is the enterovirus D68 the culprit? Most importantly, clinicians should remember that association does not prove causation, and thus more data are needed to confirm the relationship between EVD68 and the neurologic symptoms seen in some cases. So know that we don't really know about this, but this was affecting a lot of people in the U.S. They expected 2016 to have this outbreak again, but they didn't. But it's important to know as providers something that we can't really explain why this outbreak occurred in 2015. What should be our major effort preventing EVD68 transmission is keep your child from getting and spreading enterovirus D68. Wash your hands often with soap and water. Avoid touching your face with unwashed hands. Avoid close contact with sick people. Cover your coughs and sneezes. Clean and disinfect surfaces, and stay home when you're sick. Dengue fever. There's a great article on dengue fever. It's a worldview. Acute febrile viral infectious diseases can be caused by RNA virus flavivir. Other members of the same genus include yellow fever virus, West Nile virus, St. Louis encephalitis, and Japanese encephalitis virus. It's another mosquito-borne illness. 4 viral types. Infection with one type usually gives lifelong immunity to that type. Only short-term immunity to the others. Dengue virus transmission is mosquito. Incubation period ranges from 3 to 14 days. Most common, 4 to 7 days. Travelers returning from endemic areas are unlikely to have dengue if fever or other symptoms start more than 14 days after arriving home. Symptoms of dengue fever: sudden onset of fever, headache, mouth and nose bleeding, muscle and joint pains, vomiting, rash, diarrhea, hypotension, pleural effusions, and GI bleeding. Cynthia is a 28-year-old woman. Her chief complaint: otherwise well, on no medications, Gravida 3, Power 3, non-smoker, no drug use. She had a 5-day history of frontal headache, photophobia, intermittent fever, nausea with rare vomiting. She denies cough, pharyngitis symptoms, and she denies any close contacts with similar symptoms. Self-treatment with over-the-counter antipyretics with partial relief of symptoms. She was seen in the local walk-in center 24 hours ago, day 4 of illness. UA throat culture done, all normal. Advised she had viral syndrome, sent home to rest. Use antipyretics and increase fluids, we're told. Presents on day 5 of illness. I am no better, and now my legs are swollen. I am all bruised, and I do not know why. Headache and profound fatigue persists. Appetite was poor. States taking fluids without difficulty. She had mild nausea, denies diarrhea and constipation. She had a temp of 103, her blood pressure 102/80. She's alert and oriented, profoundly photophobic, Neuroexam otherwise within normal limits. Her neck was okay. She had diffuse shoddy lymphadenopathy. She had a normal cardiac and respiratory exam. Abdominal exam were within normal limits, exception of mild hepatomegaly and minimal epigastric tenderness. Her skin had extensive petechiae over extensor surfaces. Her hematocrit was 11, a little low. Her hemoglobin was 11, little low. Hematocrit 48. Platelets 12,000, significantly low. RBC 3.8, which was low. MCV of 78, so we're looking at microcytic. And RDW was a little elevated at 18. Thrombocytopenia, what is the bleeding risk? So 50,000 to 150, no bleeding risk. 20 to 50,000, minor spontaneous bleeding. 5,000 to 20,000, potential for serious bleed. At less than 10,000, usually transfused to prevent bleeding. At less than 5,000, serious bleeding risk. Cynthia, total white blood cell count was 12,000, which is elevated. Neutrophils, 68, which was normal. Lymphs, 27, which were low. And monos, 4%, which were normal. Warning signs of severe illness are worsening abdominal pain, ongoing vomiting, mucosal bleeding, high hematocrit with low platelets, which she had, lethargy, breathlessness, and pleural effusions. Due to symptoms and unclear diagnosis and profound thrombocytopenia, she was admitted to the hospital. Hemoglobin 7.7, hematocrit 22, RBC 1.4 million, WBC 3,000, neutrophils 56%, basophils 23, lymphs 18, eosinophils 3, and a SED rate of 57. She has some transaminase, which is ALT of 78 and AST of 76, which are elevated, an ALK phos of 104, which was normal, an albumin of 2.9, and an INR of 1.1. The diagnosis for dengue fever should be considered in any patient presenting with fever that has been developed within 14 days after even a brief trip to the tropics or subtropics, including those regions where dengue has not traditionally been considered an endemic disease. And that is by Cameron in the New England Journal of Medicine. So, febrile stage, high fever with headache, vomiting, myalgia, joint pain, sometimes with transient macular rash, and palpable hepatic edge, which she did have on exam. Children are usually less sick, but highly febrile. Febrile stage lasting 3 to 7 days. Remember, these patients have mild hemorrhagic manifestations such as petechiae, bruising, especially at venipuncture and injection sites. Critical phase seen in small portion of patients, usually children and young adults. They have systemic vascular leak syndrome, which follows fever. They have hemoconcentration, hypoproteinuria, pleural effusions, and ascites is common. Critical phase usually lasts 48 to 72 hours. They have a low narrowing pulse pressure, which can result in the loss of plasma volume. With pulse pressure narrowed to less than 20, with peripheral vascular collapse, and this is considered dengue shock syndrome. Intervention is urgent, although careful resuscitation. That meaning don't be crazy on the fluid resuscitation. You have to be careful with it. Laboratory findings during febrile stage: mild to moderate thrombocytopenia, leukopenia. The patient had mild to moderate thrombocytopenia, low platelets, leukopenia, low white blood cell count, moderate elevation of hepatic transaminase levels of ALT. This phase lasts for 3 to 7 days, after which most patients recover without complications. So day 1 to 5 for test options in dengue fever, you have viremia, which is they have an increased viral load there. You want to get a PCR assay. You got to call the lab, tell them you want to test for dengue fever. Also, day 1 to 7 is you want to get the ELISA or rapid test. If they present day 4, IgM, and day 5, that says day 4, IgG. Treatment, no specific treatment, hydration, rest, supportive measures of circulatory and hematologic status. If you suspect or diagnose, or there's a diagnosis of dengue, you want to avoid nonsteroidals, aspirin, and systemic corticosteroids because they use potentially can cause antiplatelet impact and other effects. So you could bottom out their platelets even more. Acetaminophen, Tylenol use is acceptable. And that's it. For my lecture, we'll be doing case studies on Monday.